When I started my internship in 1983, if you had maturity onset diabetes, the diabetes that you get as you get older that we call type 2 diabetes right now, your life expectancy was about 5 years. It was a fatal disease. It was a disease that killed you in a short period of time. Now, if you develop maturity onset diabetes at age 65, you can easily live to age 80, 85, even 90. But it requires a lot of resources, a lot of medication, a lot of time and effort by the healthcare system, and all that's expensive. So for a lot of this, the scientific developments that we celebrate in the healthcare industry cost us more money and move things forward. So where do we spend that money? Well, let's talk about where the money really goes. And I'll just share some things that come from our organization, Vidant Health. So annually, we spend about $82 million just on our share of the employees' healthcare costs. And we design our healthcare costs for our 12,500 employees that we spend about, as the company, will supply about 2/3 the money, they supply 1/3. Physician fees that we pay for call coverage and other things that we pay for teaching residents and things like that, $49 million a year. Just those yellow isolation gowns that you see sometimes in the hospital, just that one item we spend $1 million on a year. Salaries in those employees are $683 million a year. Benefits, including health care, are about $190 million a year. Just our linen cleaning and replacement is $5 million a year. Just the service agreement on the Da Vinci robot that allows them to come and maintain that and fix it when it's broken for each one of our robots is about $190,000 a year. So when the money comes in, the money goes right back out. On a monthly basis, these are things that are very, very common. For implants, hip and knee implants, we spend about $6 million a month across Vidant Health. I already told you about utilities and telephone, $2 million. Blood, about $1.5 million. Raw food that we serve in the hospital, you might not think it's worth it when I tell you the number, if you've had hospital food. It's about $750,000 a month. So healthcare is very expensive. Daily we spend, total operating expenses are about $4.5 million. Salary and benefits about $2.5 million, and just in postage, 365 days a year, about $4,500. So out of the $1.8 billion that we'll have, that we'll bring in over the course of the year, the amount of money that we put in the bank last year was $24 million. So that's what ends up going into the savings account for us to cover unanticipated expenses going forward. The largest unanticipated expense we've had this year across Vidant Health is that the state of North Carolina, for its Medicaid share, owes us about $70 million right now. So we pull money out of our savings account to pay for the care more than we put in the last 2 years in our savings account in hopes that the state will catch up on their bills and be able to pay us. But on about a $2 billion organization, $25 million is not very much money to have at the end of the year to put in the bank for something that you don't anticipate. Heart valves are between $5,000 and $12,000 a piece. Factor 7, and the reason we put that on there, the average per dose is about $10,620. We have several patients that visit us in Vidant Health that are part of our region here that have hemophilia, and I think some of you have probably heard of that. On the average, they'll spend about over $2 million in Factor 7 per year that keeps them alive. They don't have insurance, and they don't have the money to pay for that. So the people that can pay their bills pay for the Factor 7 for those two patients, about $4 million a year. So Vidant Medical Group, the physicians that are across the region that are employed by Vidant Health, the budget for that's about $160 million. A change in government regulations this year for ICD-10, we budgeted $9.6 million. A disposable instrument for the Da Vinci robot, it's about $12,000. A single surgical screw, and I don't know if anybody's broken their hip or broken their arm and had a screw put in, but it's between $300 and $1,000. So that's why the money goes out almost as fast as it comes in. So let's talk about some of those things that we talked about in this compact where we've said one thing equals another. So let's talk about a little bit about insurance, because we said insurance equals affordability. Healthcare insurance, I think I can convince you. Is anybody in the audience an insurance agent? Okay. Because every time I do this, they just look and they say, I've been trying to tell people this, but okay. Insurance only works if the event that's covered is relatively rare and the cost can be well defined and limited. And so when you insure your house, put fire insurance on your house, you're paying for the replacement cost of your house. If your house burned down and you said, I want a house just like Bill Gates, they're going to tell you, nope, you're not going to get one. You're going to get a house that's pretty similar to the one that burned down. But the odds of your house burning down in any given year are very, very small. And so what insurance does, it spreads the risk of many people over so that each can pay a little into the bucket so you can get that out. So insurance shares the risk of rare events. But all of us will need health care at some time in our lives. Usually all of us need it on an annual basis. So the question is that a rare event? So you've already broken one of the rules of insurance when you have health care insurance. We know that preventive services can delay the need for care, but they can't eliminate it. And the interesting part of that is preventive services are very recently covered by health insurance. As a matter of fact, colonoscopies weren't covered by Medicare until 3 or 4 years ago. So insurance did not pay for the preventive services, it paid for the catastrophic services. So why do insurance companies ban coverage for pre-existing conditions? Otherwise, people could wait till they were sick to buy insurance. So that would be just like if your house burned down and then you went to buy insurance from your insurance agent. I think you'd have a hard time getting that insurance. But do you get care if you don't have health insurance? And the answer to that is yes. If you don't have money and if you don't have health insurance, you can show up at any emergency room and you can get that care. But who pays for that care? There's a hidden surcharge on everybody that does pay, and those costs are displaced to the commercial population. So the Blue Cross Blue Shield, the private employers are the ones that are paying for the people who don't have insurance and can't pay, and are also paying for the people who are paid for by the government whose reimbursement rates are set below the cost of caring. So that's the driver for the individual mandate. When in the Affordable Care Act they said everybody needs to buy insurance or pay a penalty, the reason is because no one can be turned away. Everybody gets health care. Somebody has to pay for it. So it was to more than encourage, it was to compel everybody to participate in the health insurance system to spread those costs over a broader base. Can you buy insurance after your house burns down? Nope. That's a pre-existing condition. But there's a difference. Are home builders obligated to build your home if you don't have insurance? The answer to that is no. But if you don't have insurance, the healthcare system is still obligated to care for you. But that's why there's no individual mandate for homeowners insurance, and there's an individual mandate now for healthcare insurance. So when people use the argument, well, there's not a mandate for any other type of insurance in America, it's because there's not a mandate to pay for the things that insurance covers in America except for healthcare. So what we do with healthcare insurance is we fund healthcare. We really don't spread the risk of rare events. And those who participate in the insurance system also pay for those who don't. As opposed to homeowners insurance, if you pay for your homeowners insurance and someone's home burns down that doesn't have insurance, your rates aren't based on paying for their house as well. So that's the driver for the individual mandate. Let's talk about another assumption that we have in the healthcare system, and that's services that we provide equal health. Let's see if I can turn this because I want to point this out. These are all the other countries, the developed countries in the world. This axis right here is the amount that they spend per person per year, and on this axis is life expectancy at birth. Here we are at the United States. Our life expectancy at birth is less than 78 years, and we'd find this for any other measure of health comparing ourselves to other countries as well. So ours is a little bit less than 78 at almost, well, actually this is 2010 data. This would be further out here now at almost $9,000. Korea spends less but has better. Japan spends much less and has much better. Czechoslovakia, Australia, Canada, Luxembourg. All those countries spend about half of what the United States spends with better outcomes. So one of the assumptions that we made is we said if we paid for healthcare services in the United States through government funding, we'd have better health. And the answer to that is no. I read something that came out earlier this week. I wish I'd have brought it with me. It says out of the 25 developed countries in the United States, the United States scores lower on just about every healthcare outcome measure in quality and safety than the other 24 countries do. So we're not getting our bang for the buck on that. Where is it that we spend the money? So United States spending is much greater for all categories of care, particularly for ambulatory care and administrative costs. So when we look at the United States spends $7,910, and in Japan they pay $2,979. That's the big difference in the cost of cars that come from Japan. We spend more for public health and administration, more for pharmaceuticals and medical goods, more for ambulatory health care, and more for hospitals and nursing homes than any of those other countries in every one of those categories. So it's not that it's just focused in one particular category, it's across the board. You'll hear Medicaid's the problem. The state spends too much money on Medicaid. Well, across the United States from 2001 to 2012, Medicaid costs per enrollee are basically flat. And that means several different things. When Medicaid costs go up in a state, it's generally because there's more people on Medicaid than it is because the individual patient on Medicaid is getting more services. But we also know that for every healthcare service, inflation has ranged from between 3% and 7% over this time period. So what we know by looking at that is we look at the Medicare costs and private premiums and everything else in there. That Medicaid has been shifted. The cost of that has been shifted to those other groups that are paying for it. So if we take constant dollars of 100 in 2001, now for the average private premium, it's almost doubled. It's about 170 compared to 100, but where Medicaid costs have stayed the same. So that's another place where that shift has occurred. Why is it so much more expensive now? Why aren't we getting better health care? These are the top 10 causes of death in the United States comparing 1900 to 2010. And as you can see, the number of deaths per 100,000 in 1900 were about 1,100. But most people died of pneumonia, influenza, tuberculosis, gastrointestinal infections. Not anymore. Now it's heart disease, cancer, and it's less than 600 per 100,000 per year. So we've done a much better job in keeping people alive, have decreased the death rate, but a much higher expense than we ever paid for in 1900. In 1965, when you went into a hospital, there wasn't a whole lot we could do for you. Now, if you have a car accident and you have head trauma and you're brought to Vidant Medical Center, we can do $100,000 worth of stuff for you in a day to try to keep you alive. And that's where healthcare costs come in. We are the best in the world at that type of healthcare. Rescue healthcare, we're absolutely phenomenal. Let's talk about productive society. So if we have health, does it make a productive society? This is the average per capita healthcare costs by age comparing the United States to Germany, the United Kingdom, Sweden, and Spain. And really, for those of us that are young, or those of you that are young, we're pretty similar across the board here until we hit about age 55. And then what we see at age 55, our healthcare costs per age go up to an average of about $45,000 for those of us that are 90 years old. So if we're interested in a productive society, we don't spend most of our healthcare dollars in the citizens that are productive. We spend most of the healthcare dollars in the United States in the last 2 years of our lives. Whether those last 2 years of our lives are when we're 22 or when we're 82. But that's where the money is spent. Is anybody surprised by that? So up to about age 55, we're the same as every other country. We spend a lot of money on those of us that are getting older. I don't have anything against retirees and people who are old because I want to become one of them someday. So there's a thing called the Milliman Index. And it calculates every year the cost of care for the average family of 4 in the United States. And in 2002, it was $9,235. And in 2012, in a 10-year period, it more than doubled. It's $20,728. Now, what family of 4 in the United States can afford to spend $20,000 on health care? So is this sustainable growth? Let's compare that growth to inflation which is right here, workers' earnings, which is right here, the premiums that are paid and the workers' contributions to those premiums. So if your earnings have only gone up 7% and your healthcare premiums have gone up 60%, that's less to take home. And we feel that sooner here than other countries do, or other parts of this country do, because so much of it is paid by the government. And because of poverty here in this region, so much of it can't be paid for at all by anybody, and those of us who can pay for that. So let's compare this to washers and dryers and other things that went on. So what this is the time price of healthcare has more than quadrupled in the last 50 years, even as the cost of other goods and services have plummeted. And what this shows is that the number of work days, the average that would be required to purchase something back in 1950 compared to 2012. So, and they used average. So it would have taken you 23 days in 1958 to pay for your toaster, your TV, and something that played music in your home. In 2012, it takes 3.3 days. A washer and dryer in 1958 took the average hourly wage, the average wage earner in the United States, 23 working days to pay for a washer and dryer. Now it's 3.9 days. Compare that to healthcare spending. In 1958, it was about 15 days of the average worker's salary. Now it's 58.3 days. So for the average worker across the United States, you have to work the first 2 months of the year to pay for the healthcare costs that all of us spend across the United States. So is that sustainable? Is this making us a more competitive society? That top black line is the expenditures of healthcare dollars between 1980 and 2009. The rest of it is all the other countries, Norway, Switzerland, Netherlands, Canada, Denmark. And as you can see, we were all pretty close back in 1980, but the spread has continued and the spread continues to grow. So when we talk about bringing manufacturing back to the United States, we talk about bringing other industry back to the United States, we have to solve the healthcare issue problem if we're going to do that. Because one of the largest drivers that we have for all the goods and services that we provide in the United States is the cost of healthcare. And the cost of healthcare here is twice what it is someplace else, and we're not getting our money's worth. We're going to talk about why we're not getting our money's worth in just a bit. So who are our patients here in Eastern North Carolina? About 1.4 million people spread through the 29 counties that Vidant Health serves in an area roughly the size of Maryland, which makes it very, very rural, as you know. Compared to other areas of the state, Eastern North Carolina as a whole, rural communities, a few mid-sized urban markets, has a higher concentration of people over the age of 65, over 15% versus about 14% for the state, has a significantly higher percent of the population who's age 25 or older without a high school diploma. 18.3% of us here in Eastern North Carolina are over the age of 25 without a high school diploma, compared to 16% across the state. We have a higher percentage of children and adults living at or below the poverty level. A full 1/3 of us here in Eastern North Carolina live at or below the poverty level versus about 27% for the rest of the state. We have a much higher population percentage of uninsured people. People here experience significant access issues to primary care and specialists. Household incomes are about $10,000 less than the state average, and a higher concentration of minorities here, 41.5% versus 1/3 in the state in general. So this kind of talks about it, but in colors for us here. If you are green in this, you are better than the United States rate. If you're any color other than green, it's the level of poverty, percentage of households here is greater than the United States rate. And if you're yellow, you're at the same rate as the state, but still worse than the United States. Education, if you're green, you're better than the state rate. If you're orange, you're better than the North Carolina rate. If you're red, you're less than the North Carolina rate. Let's talk about some of the diseases that we have here in Eastern North Carolina in the 29 counties. And we've made Hyde County red here, each one of those. So this is 1-year diabetes mortality rates by county. Approximately 1/2 of the counties here have higher diabetes mortality rates than North Carolina in general and the United States. As you can see, Bertie, Gates, and Hertford counties have especially high rates of diabetes mortality. 1-year cancer mortality rates. We're fortunate here in Hyde County because we're at the U.S. and North Carolina average, but about 15 of the 29 counties have higher cancer mortality rates than North Carolina in the United States. And just to point out, these are real people. So what I did is I did a little bit of math on just taking 2 counties, Hertford County and Edgecombe County. And if those 2 counties had the same 1-year cancer mortality rates as the rest of the state, 60 more people would live every year than live right now. And those 60 people have real names. They're our friends and neighbors. But can you imagine if I'd have taken Gates, Jones, and Terrell counties out there? Tremendous disease. 1-year heart disease mortality rates by county. Hyde, you do pretty well here. You're right at the Eastern North Carolina average, although it's greater than the North Carolina average. But about 2/3 of Eastern North Carolina counties have higher heart disease mortality rates than the rest of North Carolina. And North Carolina is higher than the United States average. As you can see, Jones, Lenore, Martin, and Washington and Terrell counties, it's huge. So our people here are sicker. Obesity rates by county. North Carolina is above the national average, but we're right at the North Carolina average here in Hyde County. But 2/3 of Eastern North Carolina counties have a higher percent of the population considered obese. Obesity leads to disease. It leads to cancer. It leads to diabetes. All these things are hooked together. If we're going to spend less on health care, we have to take some responsibility ourselves for the health. Only 20% of the health of a community is determined by the healthcare services that are provided in that community or adjacent communities. 80% of the health status of a community is determined by the people in the community and the social determinants of health in that community, whether they're poverty, diet, behavior, exercise, genetics. It's 80%. And if we want to decrease healthcare costs in the United States, we have to do something up front. Because we're really, really good at taking care of you when you get really, really sick, but it's really, really expensive for us to do that. Where is care delivered across the United States? 80% of patient encounters are in a physician's office. Here, and these are all drawn to scale, almost 50% of all health care provided in the United States is provided in a primary care office, about 1/3 in a specialty physician's office, about 16% of it in a hospital outpatient, and that's for types of things like colonoscopies, infusions, dialysis, things like that. Only 2.8% of the health care that's provided in America is provided on an inpatient hospital basis. And as you can see, the number of visits per 100 population is outpatient visits is 405. So the average person in the United States sees a doctor or a healthcare provider 4 times a year. Only about 1/10 of that. So what we have to do is, if we're going to change this equation, we have to deliver health, not just services. Because delivering the services that we do now, where we do now, when we do now, is not providing the levels of health that we need.